Type 2 diabetes is largely reversible. I don't think that's controversial, and that's great news. Yet it's a fact that can be used to blame patients every single day, which is a problem. So as a cardiologist, that really bothers me. It bothers me a lot. And today I want to walk through kind of a thought experiment that I think has the power to maybe reframe how we think about diabetes, who gets it and why. So we live in a culture that has a complicated relationship with type 2 diabetes. On the one hand, we treat it as a chronic, progressive disease that requires lifelong medication management. On the other hand, many quietly imply that the patient brought this upon themselves, and that if they had just eaten better, exercised more, tried harder, they wouldn't be in this situation. And that narrative is really counterproductive and can be really harmful. I want to show you exactly why using a maybe simple but provocative thought experiment. So imagine you take 100 people with type 2 diabetes and place them in a fully controlled metabolic ward for 30 days. Whole foods ketogenic diet, an hour of structured exercise daily, 8 hours of sleep every night. No exceptions, no outside food, no cheating, everything controlled. On day 30, most, probably everybody, would no longer meet the clinical criteria for type 2 diabetes. They'd be in remission. Now, before you say that sounds too good to be true, I mean, you can look at what the data show. There was this direct trial, which wasn't even, like a controlled environment, and he used a non-sustainable, low-calorie liquid diet and showed 46% remission at 1 year. And of course, the Virta Health studies, they showed 60% remission at 1 year using ketogenic nutrition and remote clinical support. And again, those were real world conditions, not a metabolic world, not total control. Real people living real lives, achieving remission. So I think it's clear in a metabolic ward, it would be even better, up to 100%. The science is there and the mechanism is understood. When you remove the dietary inputs that drive insulin resistance and give the body the right metabolic conditions, it responds. But what if we run the same experiment with 100 people with type 1 diabetes? Same metabolic ward, same whole foods ketogenic diet, same exercise, same sleep, everything the same. Their blood sugar control will improve dramatically, their insulin requirements will drop, and they'll probably feel better, right? But the ketogenic diet is not going to put them into remission. No diet or lifestyle is going to put type 1 diabetes into remission. Every single one will still have type 1 diabetes. So here's the question. If type 2 diabetes is reversible in a controlled environment and type 1 is not, does that mean type 2 patients are responsible for getting sick in the first place? And the answer is no. The metabolic ward works because it removes people from the environment that made them sick. And that is the whole point, removing them from the unhealthy environment. We don't live in metabolic wards. We live in a food environment that has been kind of systematically engineered to drive metabolic dysfunction. Refined carbohydrates at every checkout counter, ultra-processed foods designed by food scientists to override satiety signals, to make you eat past fullness, to keep you coming back for more. Sugar hidden in products that really has no business being in. Portion sizes that ballooned over decades. Food deserts where the most affordable and accessible calories are the most metabolically damaging. And of course, food policy that promotes high-carb, low-nutrition foods, right? Nobody chooses that environment necessarily. Nobody picks the zip code necessarily. And nobody selected the dietary guidelines handed to them by their doctor. And speaking of dietary guidelines, let's talk about what mainstream medicine has recommended for 50 years in response to the rising tide of type 2 diabetes and obesity. Low fat, low calorie, eat less, move more whole grains, a high carbohydrate dietary pattern recommended to people with a condition that is fundamentally defined by the inability to handle carbohydrates effectively. People who were already struggling with hunger and satiety were given a dietary approach that made them hungrier and sparked their cravings. The advice itself was part of the problem, and for decades, when patients followed that advice and still struggled, the response from the medical community was often more of the same, with an added layer of implied judgment and try harder. But willpower was never going to fix the broken system. But it's not beyond hope. That's all a lot of negativity, but it's not beyond hope. We can win this battle. First, we need to widely implement dietary guidelines that prioritize metabolic health, not just calorie reduction. And the new dietary guidelines, they actually promote this, and they mention the evidence for low-carb and ketogenic nutrition in type 2 diabetes and metabolic dysfunction. And that evidence is growing and needs to be recognized as those guidelines do. Okay, and from that should be part of every clinical conversation. Second, we need to train clinicians in nutritional therapy, or at least give them access to effective metabolic health-oriented nutrition support. We know most physicians received almost no meaningful education in nutrition during medical school or residency or fellowship or whatever, especially as it relates to chronic diseases. And that has to change, but not with the same old advice that has proven ineffective over decades. And third, we need to redesign food environments and address political and economic incentives that keep ultra-processed foods cheap, accessible, and aggressively marketed. And fourth, we need to stop blaming individuals for systemic failures. That's not compassion, it's not good medicine. The metabolic ward thought experiment doesn't prove that patients are at fault for type 2 diabetes. It proves the opposite. It proves that when you remove people from the environment that made them sick and give them the right metabolic conditions, they can get better. The environment is broken. The environment needs to change. The medical system within that environment needs to change. So as clinicians, researchers, policymakers, as a society, we should be attacking that broken environment with the same urgency and investment that we bring to developing new drugs and promoting new drugs and advertising new drugs, right? What if we took that and focused it on fixing the environment? That's the world I want to see. And I think it's the world our patients deserve. So anyway, went a little bit on a soapbox. I hope this was helpful. If it was, please like and subscribe and leave a comment about what you think. Thank you for watching. I'm Dr. Bret Scher, and we will see you here next time at Metabolic Mind, a nonprofit initiative of Bazooki Group.